Today, we'll be discussing some aspects of pain. I had recently, maybe 1 week ago, I had done a quick review of pain, and before some more people join, I will just quickly try to revise few of the things which I had discussed before. Like if anyone wants to speak out, what is pain? How will you define pain? Zunera?
Sir, it's a sensation that is basically modulated by secretion of mediators like cytokines, and that is perceived in somatos.
No. Actually,
Okay.
the pain is defined by WHO. So there is a specific definition of pain.
No, I don't
Like
remember that
it
one.
is an unplaced. Is it improved, Arif? Is now the sound is better now? Is it better now? Yes, Jamil, can you define pain? J dot.
Sorry, sir. Today I am sick. I am
You
COVID
are sick.
positive.
Okay, get well soon. Anyways, pain is an abnormal, unpleasant sensation, okay, which is because of a potential tissue damage, potential or actual tissue damage, okay. So this is the first thing, and then I will show you just a second. Okay, and there are okay, so unpleasant sensory. I will just show you. Actually, I am very bad in reproducing the exact words, so I thought to just an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. This is actually by International Association of Pain. Like you can say, it is also by WHO, I think. Okay, so this is, and it has been added to as a 5th vital sign. Okay, so this is first thing, and actually there are 4 basic steps in pain. Can anyone tell? Pain pathway. What is the basic pain pathway?
Sir, I don't remember well, but it starts from the perception from the efferent nerves.
Afferent.
Then
A for apple. A for apple. It is afferent.
And then perceived in the, it was the lateral horns, and then they intercept.
I think you have not listened to that discussion. I will just make life easy. Just a second. Actually, there are 4 steps. This what you are telling is the actually you can say is the transmission. What you are telling, okay? Actually, there are 4 steps. I apologize because I even couldn't get the time to close these windows. Okay, so actually there are 4 steps of pain. One is transduction. Okay, number 2 is transmission, and number 3 is modulation, and number 4 is perception. Okay, so there are 4 steps in pain pathway. So what you were telling is actually transmission. Okay, so it is transduced by the nociceptor. Okay, and then it is transmitted through A delta and C fibers, and then one transmission is from periphery to the spinal cord, and then from spinal cord to thalamus, and thalamus to somatosensory area. Okay, so this is all transmission. Okay, this is all transmission. The first step was transduction. It is by the nociceptor. Okay, so one step, second step. Then there is third one, which is telling, and actually why I am telling you before we go to phantom limb pain or neuropathic pain, because all this is the result of this thing. Because if everything is going fine, that is what we have, the actual potential tissue damage, that is nociceptive pain. Okay, that is, yeah, you can say that the original pain, you can say, or in a funny word I will say halal pain. Okay, so the other thing which is going beyond this will be neuropathic pain. Okay, and this is what we will be discussing today. Okay, we will be starting from some aspects of neuropathic pain, and today we will be discussing phantom limb pain. So if it is going in a straight line, it is nociceptive pain. Okay, and if anything abnormal happens, this will become neuropathic pain, and neuropathic pain will have problems developing at any step. Okay, so that is important. Always keep this word in your mind all the time: transduction, transmission, modulation, perception. Transduction, transmission, modulation, perception. So first step is transduction, second step is transmission, third step is modulation. Okay, modulation is either to increase or to decrease, as the name is telling. So there is some music going on in the spinal cord, something going in the central nervous system, and something going on in the peripheral system, which can modulate the pain. Okay, so there are certain things which we discussed before. If you want to see, I will share the link of that discussion when I upload this video. Okay, so this one is the gate control theory. Okay, gate control theory. The other thing is in the peripheral tissue is hyperalgesia. It happened because of the neurotransmitter which was being released. Okay, and then something happens in the thalamus, and here there is a role of ketamine, for example, and there is a role of opioids. Opioids is everywhere, but in thalamus, ketamine. That's why actually one role of ketamine is because there is one thing which is abnormal, and it occurs in, it can occur in any patient with opioids. It is called as hyperalgesia. Okay, so that's why you see, if people are not aware of using ketamine in every patient, but believe me, ketamine can be used in almost any patient if you are using it in analgesic dose. Okay, and its effect of is anti-neuropathic and anti this hyperalgesic. Okay, if you are using in a background music a very small dose of ketamine, it will not harm anything. Rather, if you have a patient with pain, and a result of pain is the sympathetic activation and all the problems which are there, if you are giving in a very low dose of ketamine, it is actually helping. So this is one. So this is all modulation. Okay, and the last step is perception. Okay, and perception occurs in the brain, and that's how why there is role of antidepressants. Okay, they are not analgesics, but they are being used, antidepressants, these anti-epileptics. Okay, like gabapentin, this is SSRI or SNRI. Okay, or even you will be surprised that perception also acting by paracetamol. Paracetamol is not anti-inflammatory. Okay, so the other anti-inflammatories which are being used are there at they are not only decreasing the transduction and transmission, also they are actually doing the modulation as well, NSAIDs. Okay, that's why the concept of preemptive analgesia. So these are the things which I just wanted to have a review. And now, because all this will be in abnormal state, and then it will lead to neuropathic pain. Okay, some of them or all of them are in bizarre in neuropathic pain. Okay, so that's where we will enter into the neuropathic pain. And there are so many examples of neuropathic pain. Can any one of you give some examples of neuropathic pain?
So it's the same that we are doing, the phantom limb, the back pain, and
Clear
diabetic.
examples of neuropathic pain. Diabetic neuropathy. Okay. Then this phantom limb pain. Okay. Then this post herpetic neuralgia. Then the CRPS. These are few examples of neuropathic pain. Okay. So yes, I think I was disconnected. Yes, trigeminal neuralgia also. Trigeminal neuralgia, because there are so many reasons of trigeminal neuralgia. One of them is this related to herpes zoster as well. Okay. So trigeminal neuralgia, yes, is also neuropathic pain. Okay. So, and they are saying it as dysfunction, as the updated definition. They are saying it as this one dysfunction rather than disease. Okay, maybe some new development if it has occurred. I wish we have anyone who can correct us. If I found something new, I will just share with you. Okay, so this is what I was telling you: post-herpetic neuralgia, trigeminal neuralgia, diabetic neuropathy, phantom limb pain, post-traumatic neuropathy. Okay, this post-thoracotomy or post-mastectomy pain, spinal cord injury, post-stroke pain, and the pain in multiple sclerosis. Okay, so as we said that, as I told you that there is problems related to the periphery, or there are problems related to the descending inhibitory control. Okay, or you can say that is the word disinhibition. Okay? And there is abnormal activation of sympathetic system. Okay, and then what is occurring in the central nervous system and peripheral sensitization. Okay, peripheral sensitization, maybe it is a result of the damage to the nerve. Okay, that is usually which leads to CRPS, actually, this complex regional pain syndrome, in which either there is some tissue injury or direct nerve injury, leading to abnormal sympathetic activation and leading to all the we will discuss CRPS later on. Okay, so they see after nerve injury, there can be increased expression of sodium, calcium, leading to ectopic discharges and reduction in threshold for activation of nociceptors. Okay, like they are autonomous. There is no clear-cut injury, but nociceptors are singing. Okay, and they are being singing because the channels or receptors, which are the mechanism which is keeping them relaxed, they are autonomous, and they are discharging the impulses. Okay, and then when this is also true in the form of this phantom limb pain, because in this phantom limb pain there is development of neuromas, there is nerve injury, and there are abnormal neural tissue which is developing, sprouting of new nerve projections. Okay, collateral sprouting can alter sensory properties and manifest as expanded receptive fields. All these phenomena can lead to altered pain transmission. As we discussed that there are abnormal terminologies. Allodinia. What is allodinia? Like someone is touching you and you are...
It's exaggerated pain.
Just a second.
Like even if it's
It is
exaggerated pain,
pain. It is pain from that objects that usually is not painful.
Yes.
Even cloth, if the touch of the cloth or and cotton or any other things,
Yes,
you feel the pain.
I request you, all of you, the screen was not on and nobody mentioned that the screen is not visible. So I am supposed that everyone is listening and everyone is involved, because I just saw that the screen was not on because I got disconnected. So please keep me awake and keep yourself awake as well. Okay. So yes, sorry, Jamil. Actually, yes, that the non-painful sensation is transmitted as pain. Okay. So that is allodynia. Okay. So this is the peripheral one, and then dorsal horn of spinal cord houses a complex network of connections between the incoming sensory neurons and output neurons via local interneurons. The summary is that it is the spinal cord is doing a phenomenon. It is called as wind up phenomena. It is increasing. It is transmitting too much. Okay, so these connections are under the influence of descending pathways originating from the brainstem. So what happens that usually there is you can say the grandfather effect. So the grandfather effect is from the descending inhibitory pathway. So when there is too much movement there, after some time, this control is going you can say inhibited. So this is called as disinhibition. Okay, so that's what it's written here. The sustained activation of nociceptors lead to activation of key excitatory amino acids receptors such as NMDA. So that is why I mentioned that role of ketamine is of very importance in this prevention of this hyperalgesia. Okay, in the leading to central sensitization. In some patients, there is reduced activation of brainstem descending inhibitory pathway and endogenous opioid, serotonin, and norepinephrine, resulting in central neuropathic pain. This is because of disinhibition. Okay, initially there is sensitization, and then also it is added by this inhibition, that the area is more sensitized, and the control which was there to control these things is also gone. So it is increasing the severity of the neuropathic pain. Okay, so injury of the nerves can also lead to spotting of sympathetic neurons into dorsal root ganglia, of injured sensory neurons into the dermis, that is in the sympathetically mediated pain. So there is vasoconstriction, and then there is temperature changes, there is skin changes, okay, which will occur and leading to damage to the muscles, even which occurs in the CRPS. Okay, so here they have just this is like they are telling that there is peripheral sensitization. So more impulses are going towards the dorsal root ganglion, and there is hyperexcitability. It is going towards the interneurons, and then there is disinhibition, which is the inhibitory control, which is there, as I given the example of the grandfather. So the grandfather effect is going down. So when grandfather effect is going down, everyone is fighting. So this is the condition which is happening in the result of neuropathic pain. So this is just a comparison between, like, it is maladaptive, it is adaptive, spontaneous, usually difficult to identify cause, and it is vague, that it's not clearly identifiable. Nociception is clearly identifiable. Usually it is self-limiting and is responding to the normal analgesics. Okay, and it is chronic, and there is damage to the pain pathways. Here the pain pathways are intact. Okay, because the disease which we will be studying today, it has two components. One is related to nociceptive pain, and other is related to neuropathic pain. Okay, so I will leave it up till here, because this is the basic concept we should be needing. Now you can, Zanera, you can tell that what is phantom limb pain.
So the phantom limb pain is actually it's a pain that occurs after amputation.
Okay.
It can occur immediately within a week, or may occur later after a few years. There are some risk factors for phantom limb that comprises on the bilateral limb amputation, pre-op pain, and comprises of also on like
just give me a second, please. Assalamu alaikum. Sorry, I'm sorry. Yes, please. Actually, you know,
so it's basic.
Whenever you are explaining the way you should be, that it is a neuropathic pain, so you should be starting the word from like that. That it's what is basically, you know, words may be anyone, okay, but usually if you are explaining whether it is nociceptive pain or it is neuropathic pain, so it is neuropathic pain, okay, resulting from amputation. After amputation there is something missing, am I right? So the
Yes.
pain developing in a part of the missing part of the body which actually is not there. So in addition to the limb, can it occur in any other after any other operation?
It can occur in mastectomy,
Okay.
removal of rectum,
Hmm.
testes, tooth, eye, and
Digits, not really limb.
digit.
Also it can occur
Yeah,
in digits
fingers.
as well. Okay. So it like you see sometimes one digit is removed, so even it can cause pain in that one. So this is the basic. If someone asks you what is it, you will explain like this. So first step in that thing will be okay. Now the other thing is that what is the pathogenesis, how it develops.
It consists of the pathogenesis is by now it's still unknown, but it comprises of mainly on the peripheral somatosensory, and there was one more.
No, you see,
I just didn't like.
I will give you. You see, my purpose of all these lectures is not to teach you, is to guide you. Okay. So again, I will say that one is son, one is father, and one is grandfather. So now you will not forget it. Son is the peripheral system. There is a father as well. So father is the spinal cord, and the grandfather is okay, is the brain. So now you can
Can
tell
you
me.
come again with this? So sun is the spinal cord, right?
No. Son is periphery. Okay. Sun will be
Dr.
peripheral.
Dishan, can I explain a bit?
I'm sorry. Yes, please. Sure.
Yes, there are three theories about this pain. The peripheral theory, the spinal cord at that spinal cord level, and the central level. That the peripheral problem is that the region where the amputation has occurred, the peripheral nerves, they are damaged and they sprouted to form neuromas, and that will cause the pain.
Hmm. So that's what
And
actually I was giving the example of son, father, and grandfather. Okay. So if you take peripheral tissue as a son, okay, and there is the place where there is injuries there, okay, like here it is amputation. So there are some mechanism which are generating because of the. So that's why because what is stump? What is in just to add on it? What is stump pain? How will you differentiate between phantom limb pain and stump pain?
the
Stump
phantom
pain
limb
is
pain, yes.
Please, one of you. Yes, who was speaking? Please continue.
you can continue. Who was speaking? It's okay.
Yes, phantom limb pain is the pain of that region that is not present, has been amputated, uh, and the stump pain is the pain at that stump area.
No,
That's what I
actually,
know.
again, I will try to make it simplify. Yes, you now, Shimail, you try. What is the difference between stump pain and phantom limb pain?
Yes, I was telling this.
Yes, you were also telling this. Yes, Dr. Sadia, you rose the hand. Please, what do you want to say?
Stump pain is actually this nociceptive pain.
Yes. Okay. So you have to tell that stump pain is the original halal pain, which should be there because of the area where this, and you can say the surgical, you can say that it is a surgical pain. Okay. But if, for example, that acute pain is not treated, number one, number two, there is now the abnormal things start to occur that can lead to phantom limb pain. Okay. So this is the concept of difference between stump pain and the phantom limb pain. So this stump pain is nociceptive. Okay. And if, for example, there are chances, because usually what happens that this patient which is going for amputation, usually has some clear-cut problem, which is the end result is ischemia, whether it is diabetic ischemia, diabetic foot, or it is because of any limb ischemia. Okay, so whatever the reason is, usually there is ischemia and there is dead tissue which is there. So all that area is is an abnormal condition. So there are more chances of infection. Okay, the acidic area where there is less blood supply, there are more chances of infection. The organism will try to grow. Even in that area, local anesthetic does not work much. The reason being that in acidic environment, the ionized portion becomes more than unionized portion. So the effect of local anesthetic also is decreased. So that is the concept of like how the stump pain can be can become phantom limb pain. Okay, now you understand?
Yes, sir.
Okay, so then what is the next step on it? Like one is this peripheral desensitive, like peripheral cell. I'm sorry, I'm trying to increase in size. Just a second.
The next one is spinal cord, at the level of spinal cord.
So what happens there?
The nerves that were supplying that particular area that start sprouting in the lamina 2 of dorsal horn and cause pain at that area. This occurs at the spinal cord level.
Yes, that's what I just discussed in neuropathic pain as well. So actually pathology is the same as it written here. Okay, so there is like central sensitization of dorsal horn cell, and there is anatomical reorganization. A beta fibers usually are touch. That's the I taught you people that this gate control theory, which is there for electrical therapies as well. It is that A delta fibers, which are relatively smaller, they are activated when there is pain, and when you rub the area or you touch the area, the fibers which are activated is A beta. Okay, so beta for big. So big fibers, they are closing the gate in the spinal cord. Okay, so that is the concept of gate control theory. So here, that gate is actually now it is occurring in an uncontrolled way. So even the touch is telling you it is a pain. Okay, understand?
Yes.
So they like the mechanism which is there to help now itself becomes a problem. So that is what is happening here. Okay. Okay. So this is the mechanism which is occurring in the spinal cord. And now the third is the
Yes, and then
supraspinal.
the
Yes. What happened?
central,
What happens actually?
that is the reorganization of that cortical areas.
So there is
which
problem
were
in the remapping.
entered, yes, remapping.
Because there is
Here I
something.
have a question, sir.
Yes.
The remapping in the supraspinal mechanism, does it relate with the projection law?
I'm sorry. What do you mean by projection law?
It's a law of projection that says that no matter where along the pathway, like if the nerve is stimulated, no matter if the part is present or not, the receptors will be stimulated and the stimulus will be felt. Sensation will be
I
felt at the site.
cannot. Yeah, that it makes sense, but I'm not sure. Okay, so I'm unable to comment on it. But usually, you see that there is specific. There are somatosensory areas in the brain. I will just show you the article which I opened actually. Just a second. So there are somatosensory areas which are there. Okay, so there. Okay, so there are specific areas. So what happens that when something is missing, there is readjustment of the area. Okay, so this mapping process is bizarre, and that is not able to perceive that now that part is not there, and it is perceiving as pain. Okay, even there is the patient is trying to have a squeeze in the hand, and actually that is resulting in contractures in the hand, in the above elbow, okay, in the forearm, because there is the hand is not there, and brain is perceiving his hand is there, and the muscles are contracting. Okay, so that is, I'm not sure what this exactly this projection law is, but this is what happens in here. Okay, so that
It's mentioned in one of the articles you sent,
Mhm.
and it was in the article. I don't remember in which one. And it relates like if we stimulate or no matter the wrist or the hand, the perception will be felt at the elbow. It was
Yes.
something like that. I don't,
So
I,
it is
I
the
can't
same thing.
recall it now.
So it is the same thing. The you one thing which I did not mention, this one is phantom pain, one is stump pain, and other is phantom sensation. Okay, so there is some sensation other than pain, that is phantom sensation and phantom in common coexist. Bone and post amputees and pre-amputation limb in shape and size and may include feelings of posture and movement. Okay, describe feels of warmth, cold, itching, tingling, and electrical sensations. Phantom sensation usually appears soon after amputation and can last from weeks to years, but it is not experienced as being painful. Okay, so this is a separate thing which they can ask you, that there is one thing which is occurring is phantom sensation, and then it becomes in the form of pain. Okay, so that is a component, you can say. Okay, some patients also describe the phenomenon of telescoping. This is where the distal part of the phantom limb is felt to be closer to the stump or within the stump itself. For example, forearm amputees may describe feeling that their amputated hand is attached to their elbow. Okay, this probably occurs because the cortical magnification of hand is proportionally overrepresented on the somatosensory cortex. Actually, you will find in the books or article too many things, but the summary which you will recall is that like that what I'm telling you, because that is the one which even I can remember even after so many years. Okay, so just try to make it simple. So first step is that the pain which is occurring immediately is stump pain. Usually it is nociceptive pain. Then some abnormal sensations start to develop. And the involvement is of peripheral system, spinal cord, and the brain. There is remapping problems. The brain is unable to understand that something is missing, so it is constantly sending the messages related to that area which is not there actually. So that is what the main chunk of phantom limb pain. Okay, so some of the things will be written here as I discussed with you. It can occur, you see, testes, penis, breast, eye, tongue. There can be sensation over there. Okay, and as like any, because this is a neuropathic pain, it is like not very exact pinpointed, and it has different character, as we know that sharp pain, it is a dull pain. Okay, and there may be a development of abnormal pain sensation which we discussed before: hyperesthesia, hyperalgesia, okay, allodynia. So any abnormal pain sensation can develop, okay, in the pain in the phantom limb area. Okay, so this is what is stump pain is common in the early post-operative period. It is acute nociceptive pain. Okay, and it will resolve when the wound heals, usually due to ongoing local pathology or at acute neuropathic process, because I told you that stump pain can lead to phantom limb pain if there is some development of osteomyelitis, abscess. Okay, so this we have discussed. The peripheral mechanism. Okay, there is neuroma formation, and there is A delta fibers and C fibers. They are like there are neuroma formation there, abnormal expression of channels. Okay, and then spinal mechanism, there is hyper excitability by abnormal spontaneous activity and exaggerated response to mechanical and thermal stimuli. Okay, sensitization of dorsal horn neurons occurs in response to increased painful stimulus from the amputation site, and it is mediated by the release of pro-nociceptive agents like glutamate, neurokinins, which is there normally, but it becomes oversensitive. When it becomes oversensitive, it will lead to this development of this neuropathic pain. Okay, and this is about the cerebral mechanism, as I told you, that it is because of the the area, you see, consequence of errors occurring in this remapping process. Okay, areas of somatosensory construct which is previously corresponding to the missing limb subsequently receive sensory information from other area of the body that synapse at adjacent areas on the somatosensory cortex. Like the thing is not there, but the area, what is it has to do? So it is receiving impulses from the other areas and it is perceiving as if it is in the missing area. Okay, so this is what is the main. If someone asks you, or any question if they will be asking you, will be related to these 3 steps. Okay, so prevention, then that is a concept of preemptive analgesia, which I told you that development, giving some analgesics, modifying the response to the pain even before stimulus has been given. Okay, so this is the what is the concept of preemptive analgesia. So preemptive analgesia will help. There you can give epidural, you can give spinal, you can give this one and this perineural catheter. Yes, Zunaira.
Sir, there is in the cerebral mechanism on the last line, there's written like this can be demonstrated by clinical examination of sensation, which may show a somatotropic representation of phantom limb on the chest wall, in the stump or on the face. Like, what does it, like when we are giving a stimulus, they will show, like there will be representation how on the chest wall. Like it's, they are saying like it's a demonstration of the pain.
This will be, I think, abnormal sensation. I'm not sure about this sentence. This can be the degree of reorganization is related to perceived pain intensity and reduces with effective treatment of pain. This can be demonstrated by clinical examination of sensation, which may show a somatotropic representation of the phantom limb on the chest wall, in the stump, or I'm sorry. But actually, the chunk concept I have told you, I'm not able to understand what does it mean. This may be that this whatever
it means that it's based on post mastectomy or something else, or surgery in the chest wall, and it's give the mechanism, central mechanism of frontal limb pain.
Anyways, I don't understand fully. Okay, so okay, so preoperative epidural, if you place, this will be result in decrease the incidence of severe phantom limb pain. Okay, and treatment, all the neuropathic pain medications, SSRI, tricyclic antidepressant, SNRI, the selective serotonin and norepinephrine reuptake inhibitors like duloxetine. So the same medications are being used. Gabapentin, there is a WHO step ladder. They start with the paracetamol and simple analgesics, and then they go higher up. Okay, in addition to all these medications, you see tricyclic antidepressant. Okay, this is SNRI, duloxetine, which is used also in diabetic neuropathy. We will discuss in detail in neuropathic other aspects. We will try to have this nice guidelines for neuropathic pain. Okay, so SSRIs, and then these anticonvulsants. Okay, voltage gated calcium channels and sodium channels. This gabapentin, it also is used for preemptive analgesia and also for reducing the requirement of opioids in other patients as well. So, sorry. Yes, Talha.
Sir, I asked my father, he's a neurosurgeon. If you allow me, he will explain this line.
Sure. Yes, please.
What I consider is like maybe they're saying that.
Yeah, let him speak. Let him speak, please.
This means that if the patient is touched somewhere else, for example, on the chest wall or somewhere else, which is the normal body part, he will feel pain
and there.
He will feel pain in there, which is not there. He will feel pain in the limb, which is not there, the phantom limb.
Okay. Thanks a lot. So you understand that I was thinking that I was like the meaning was, but I was not sure that is it possible that phantom limb pain is occurring in chest, I was not sure. Okay. Thanks a lot, sir. Thank you. Okay. So treatment we just does. This is because one thing which is extra for in addition to this the normal medications which are being used in chronic pain or in neuropathic pain is mirror therapy. Okay, mirror box. So mirror box is a device containing a vertically placed. I have never seen it, so I may not be able to. Yes, Dr. Sadia. You want to say something, Dr. Sadia? Your voice is not coming. Are you?
So clonidine agonists also play a role in its treatment. NMDA receptors antagonists like ketamine and memantine also are used in as therapeutics.
Yes, ketamine. I told
also,
you that
sir,
the mechanism because of hyperalgesia. Okay, and this what will be the role of clonidine?
They are a clonidine agonist as they act on alpha-2 adrenoceptors.
Yes,
so,
this is presynaptic, and it decreases the sympathetic outflow.
Yes, exactly. And also, sir, these botulinum toxins are also used in the treatment. Pulsed radio frequency ablation of the neuromas is also used in the treatment. Monoclonal antibody-based therapeutics are also in practice for the treatment of this phantom limb pain.
Yes, actually, you know, when they are asking the question to you people, like we are not a pain specialist usually. Okay, so in anesthesia exam, you just should have a concept. Number one, what is the basic mechanism, and what are the possible therapies? You see here, I just bypassed myself. This one, calcitonin, it is written here. I was reading about it because I have never used it. So I have no idea how to use this calcitonin. It was written somewhere here, I think. Anyways, so role of ketamine is of utmost importance. Clonidine, as she told, and then some of the this novel medication. Okay, so mirror box. Can anyone explain mirror box? And Jamil, can you explain mirror box, because I'm not very good at it. There is they are just trying to reproduce the mirror image of the thing which is missing. I will just try to read out.
Yes, they put the one mirror in front of that limb which is amputated, and they make some that limb also, you know, the wooden or by plaster or something else. They just give him the to wear that limb, and front put a mirror in front of that limb, and gradually the map is developing centrally in his brain that there is now there is one organ. Repeatedly when he say in the mirror of that organ, it will help to reduce to reduce the phantom limb pain. You understand?
Yes. Actually, that's what I have not, of course, I have not seen how they do it. So the thing which you have not seen, maybe you are not able to explain, but usually what happens that when this reflection is being shown, so gradually there is activation of the sensory system, and it will reduce, and it will result in the reduction in pain. Okay. Yes, Dr. Sadia.
Sir, there is a picture given in this Oxford journal, I guess, in which the patient is asked to put both his arms in a box, and the mirror is just towards the limb having the whole, the mirror is towards the one which is intact. Okay. So he sees his arm, and he thinks that his hand is still there if its upper limb
Thanks a
is
lot.
missing.
This is, I think this is also a good explanation which you have given. Thank you. Thank you. Okay. So you see, this is how you should be just targeting. And as I told you that role of preemptive analgesia, and you are putting epidurals, you are treating the acute pain, you are treating the stump pain, you are trying to avoid infections. Okay. So that will be leading to prevention, but nothing is absolute. There is no absolute prevention in any. You see, the incidence is so high that it occurs in almost 70 to 80% of amputees. So it's a very high percentage. So there are so many things which you can do to prevent it, but no, none of them is 100% effective. Okay. So like they have written here, immediate fitting of stump processes can be helpful in the management of phantom pain. Okay, psychological, antidepressants, electrical therapies. There are so many things which you will find in different articles. Yes, let me show you, because I had a look in the morning. Okay, so that one was slightly older one. This is slightly this is what I found, something new, which was new for me as well, that there is ossification in the stump area by the deposition of calcium. Okay, so this is also resulting in exaggeration of pain, and if it is not inhibited, then they may need to remove this ossification. This was, I have never read it before. Okay, so neuroma infection. Okay, so you see, this is infection, wound breakdown, arterial insufficiency, osteomyelitis, bone spur, hematoma, insufficient myoplasty covering. Okay, and poorly fitting prosthesis. These can lead to prolongation of these problems. Okay. You see, gold standard for the management of post-amputation acute stump pain is regional anesthesia. As I told you, they can put epidural, they can put wound catheters, perineural catheters. Okay, in the form which will be giving a very good pain relief, and it will be resulting in slightly reducing the incidence of phantom limb pain. Okay, so you see written, phantom limb pain occurs in up to 80% of amputees. Okay, so this is something very high incidence. So you can just try to minimize the incidence. Okay, so severe postoperative pain, bilateral amputation, stump pain if it is continuing, repeated limb surgeries, increasing age, or patient has already some psychiatric problem or neuropathic problem. So in those patients, there will be more chances of development of this phantom limb pain. I tell you something, because I get this response of how to read all these articles. You have to study like I'm telling you. Okay, if you try to read each and every line, you may be confused. So try to swallow as much as you can. Okay, because at the end of the day, you just have to chalk out what questions may be asked from this topic. Okay, usually the novel medications or uncommon things which is not well acceptable, they don't make questions on. Usually they don't make questions out of it. So in oral exam, you can say that there are some new modalities which are being used like that, like this monoclonal antibodies and things like that. Because I'm not very expert in this topic, so I'm just giving you a main concept. If they are asking you ever this topic, this is more than enough knowledge. Because you see, if you are appearing in any oral exam, usually one scenario will be 4 to 5 minutes. So the things which we have discussed, they will ask you in this: what is phantom limb pain, what is stump pain, how it develops, what is the pathology. You will be telling that there is peripheral mechanism and spinal mechanism and supraspinal mechanism. Then how can you prevent it, how can you treat it? So in this 4, 5, 10, then in the MCQs, they will be asking you that, for example, about mirror therapy. They can ask you that, how it occurs. So they will put some things that it is occurring on the spinal cord or occurring on the brain or whatever. So that is how they will be. So try to become an examiner. I will quote the word of one of a legend of anesthesia, and I owe a lot to him. He's no more. Is Dr. Sajid Usman Call. So his word was that if you read a page and you are able to make a MCQ out of it only then you can say that you know the subject. Okay. So just try to make questions whenever you are reading. Just try to see that what questions may be asked. And if you trust your capabilities, you can do it. But you don't do it because you don't trust your capabilities. You think that like I'm nothing. Okay. So actually, if you just try to figure out the base of the topic. So I will just, in few minutes, I will just quickly revise that we started from the basic pain pathway. We just touched how is the pain is transmitted. And then we see, because why I told that, because this whatever abnormal thing occurring is in the pain pathway. So we see that there is problem in the transmission, there is a problem in the modulation, and there is a problem in the perception. So you see, this is what is occurring in the first step is for stump pain, that is transduction. And then after that, there is abnormalities in the other rest of the pain pathway, which is resulting in the development of this phantom pain. Okay. So I hope we have just tried to have given some respect to this topic, though it's a difficult topic. And you see, that's what you were telling. That's what I was telling you. This salmon calcitonin. I have no idea what is it. I think it is some fish, salmon fish, if I'm not wrong. So they are taking this calcitonin and they are trying. But if you people as this exam, if you are trying to tell this as first, you will be caught. Don't try to be over smart. You should be trying to be on the basic simple things first, antidepressants and anti-epileptics, and there is a role of ketamine. There is a role if you are putting epidurals or perineural catheters, it will be helping. And there are some new strategies. This is what I forgot to tell you, that whenever there is missing limb, and in addition to all other things, when they are trying to rehabilitate, we are putting the artificial limb, there will be because the weight distribution on which will be coming to the back will be disturbed. So there are more incidents of back pain, okay, which may be there before, but it will be exaggerated after this amputation. Yes, Dr. Sadhya?
Sir, this calcitonin is a neuropeptide given in the dose of 100 international unit over a day subcutaneously for 5 to 7 days. And they say that it has a quite promising effect in the treatment of this phantom limb pain.
Yes, that I'm telling you that you should be trying to grab it, but don't try to read each and every line, because you just this should be your notes, which you told, okay, that it is recently being used. You see, novel analgesic, okay, novel medications are which are newer medications, okay. So you just try to have if I were reading this, I will just take this word and I will just write down this neuropeptide, novel analgesic, dose. Okay, if I can do it, otherwise I will finish this in this paragraph in 1 minute, because rest of things are useless. You understand my point? That's how you have to sniff these articles and just try to, whenever you are having a look at any medication, just try to see what's its tribe, what is its qabila, what is its caste. So if you're asking about gabapentin, it is anti-epileptic. It is acting on voltage gated channels, okay, and it has it is being used for opioid sparing, okay, and it is for prevention of chronic post-surgical pain. Thank you very much. This is more than enough. If you want to read from this, yes, and there is, these are brother or sister, gabapentin, a little different in this pharmacokinetics. This is more potent, more pregabalin. So that's how you should be. NMDA receptor antagonist, that's what I read in the morning here. Anti-neuropathic, anti-nociceptive, anti-hyperalgesic. This is role of ketamine via NMDA receptor antagonist. Okay. So ketamine, if the side effects which are there in when you are giving in high dose, if it is being removed, the ketamine is a wonderful medication. I love ketamine. I use in every patient, and even in whatever contraindication is written in the books. Of course, you cannot say in the exam, but practically in low dose ketamine is like a magic. Okay. Anyways, I think that's enough for this topic. So tomorrow we will be discussing some words about smoking and some airway reflexes which are there as a result. Yes, Dr. Sadhya?
Sir, one last question. In this perineural blockade, they have mentioned this ropivacaine only. So, sir, I was asking that only this ropivacaine is used.
Yes. This is
like
a very
no,
good
no
question. So
other-
tell me one thing, what is difference between ropivacaine and ropivacaine?
Sir,
Actually, you
I
can say it
don't-
is, again, I will be, because I try to simplify the thing. You can say it is a brother or sister. They are isomers. Okay. So actually, bupivacaine and ropivacaine are the same. They are a little bit different in structure, and it is less cardiotoxic. And this is number one. And number two, you have more margin of dose. And then another thing is that it is less motor blockade. Okay. So that is the only reason which they may have mentioned. Otherwise, there is no difference. Okay. They have written here, I can see here, but ropivacaine, because it's not available, I have even in the people where it is available, people still, because there is not much difference. If you are giving, you are using it as a intraoperatively for motor block, I think there is not much difference, because ropivacaine you have to give a little higher dose. Okay, and ropivacaine is better for post-operative analgesia for the same reason which I told you, that we don't want motor blockade. Am I right? So that's why it is used in the concept of this, even this walk-in epidural. There is a concept of walk-in epidural in which they try to have a pain relief, but make sure there is no motor blockade and patient, or less motor blockade, and the patient is even can mobilize with the walker. Okay. So that is the difference between ropivacaine and bupivacaine. Okay. I hope I clarify the answer. Okay. Again, if you just try to reproduce only this thing, then you will be in trouble. They have written in a context. Okay. So, but you should be thinking that what is the reason for it? I don't think so that there is any other reason for it. I don't find it. I'm maybe there is some specific reason. I'm not sure, but that will be a higher level knowledge. I don't think so. They will be asking you this in your exam. Okay. Okay, everybody. Thanks for your presence. And tomorrow, inshallah, we will meet again with a new topic. Okay. Thank you.